the first presentation is going to be by Katie Dingus, who is the Certification Unit Manager at the Department of Public Health. And Katie's going to provide an overview of the four elements of an emergency readiness plan. And she's also going to share some of the most common deficiencies that DPH has been seeing recently in its survey. So Katie, I'll pass this over to you.
Thank you. I'm just going to share my screen. Okay, so yes, my name is Katie Dingus. I'm the Certification Unit Manager with the Department of Public Health and Division of Healthcare Facility Licensure and Certification. I am the manager of the Life Safety Code team. So our Life Safety Code surveyors are the ones that do the emergency preparedness surveys when they go into the buildings. They do that in conjunction with their Life Safety Code survey. So I'm going to go over the four core elements of the emergency preparedness plan. There's a lot more information in my slides than I will actually be speaking to today, but I did that for educational purposes. When you receive these slides, you'll be able to, use this to help you make sure that you're creating a robust plan. So please understand, there's a lot of words on some of the slides, but they're not all going to be read. So our Life Safety Code surveyors use Appendix Z, the emergency preparedness for all providers and certified supplier types. So that's a state operation manual, Appendix Z. So it's where all the regulations can be found. And any Medicare or Medicaid programs have a requirement to participate with Medicare. The requirement is that they have an emergency preparedness plan. And in order to they establish the rules so that way all facilities will understand the four components ultimately. And it is required in order to maintain your CMS certification and your Medicaid funding. Final rule also assists providers and suppliers to adequately prepare to meet the needs of patients, clients, residents, and participants during disasters and emergency situations, striving to provide consistent requirements across provider and supplier types with some variations. This is a long-term care panel, I believe. So this does apply to hospitals and other healthcare facilities. Nursing homes do have some specific regulations when it comes to the review of their plan. So each long-term care facility must comply with all applicable federal, state, and local emergency preparedness requirements. They must establish and maintain an emergency program that meets the requirements of the section. And the emergency preparedness program must include, but not be limited to, the following elements. Number one, the emergency plan. The emergency preparedness program does come with a set of conditions, and then there's standards underneath that can be cited related to each condition. So the main component conditions are emergency plan, which is at E04, policies and procedures, which is at E13, communication, which is at E29, and training and testing, which is at E36. So the emergency preparedness plan, the facility must develop and maintain an emergency preparedness plan that must be reviewed and updated at least annually in nursing homes. So the condition is the E04, but the standards that could be cited are E6, E7, E9, and those are all encompassing under that one condition. So you might find that your condition is not out, but you got a standard level citation for E09, which would be cooperation and collaboration with local, tribal, regional, state, or federal emergency preparedness officials. So they look at each standard within the condition. You always have to have a hazard vulnerability analysis. In risk assessment, there are systematic approaches to identifying hazards or risks that are most likely to have an impact on the healthcare facility and the surrounding community. We in New England know that we really focus a lot on snow, in cold weather. We have a lot of preparation, on Fridays when we know there's going to be a big snowstorm on the weekend, or there's going to be a really cold snap coming through and we're afraid about pipes bursting in facilities. We see it all too often. But we also have to look out for fire emergencies, things like that all over the nation they're looking at. The healthcare facility risk assessment reflects the specifics of the facility location, whether it's, flooding zone, anything like that. and characteristics. There is significant mutual benefit from a joint community risk assessment with other facilities and jurisdictional partners. So that being said, you would want to make sure that you're arranging part of your plan to, speak with the local fire department, local police officers, and any city municipality that might involve an emergency plan that you are working on to keep your residents and staff members safe. Your risk assessment should, once again, very similar to the hazard assessment analysis. So natural disasters, man-made disasters, facility-based disasters that can include care-related emergencies, equipment and utility failures, interruptions in communication, including cyber attacks, which we have been seeing throughout the nation, not just in the state of Massachusetts, loss of a portion of a facility, interruptions to normal supply of essential resources like water, food, fuel, etc., and emerging infectious diseases like influenza, Ebola, Zika, and others. And they have lumped COVID into the, respiratory. It's still its own, but the respiratory outbreaks is part of this. So the next line is policies and procedures. Your facility has to develop and implement emergency preparedness policies and procedures, a risk assessment in the communication plan at your facility. The policies and procedures must be reviewed and updated at least annually. And at a minimum, the policies and procedures must address everything in E15. So if you go into Appendix Z, you'll find E15 will talk about what your emergency policies and procedures need to entail. E18, E20, E22, and E23 are all standards that are followed underneath E13 for policies and procedures. So we want to make sure that your policies and procedures are addressing all of these standards. There's continued ones. Policies and procedures is a very long condition. So E24, E25, and E26. The communication plan. The long-term care facility must develop and maintain an emergency preparedness communication plan that complies with federal, state, and local laws and must be reviewed and updated at least annually. The communication plan must include all of the following. This is a really important one because we do find there's a lot of turnover in nursing homes and people forget to update the communication plan. So names of contact information for staff, entities providing services under the arrangement, residents, physicians, other long-term care facilities. If you were in an emergency situation, you need to evacuate, you'd need to be able to contact local long-term care facilities for potentially receiving your residents. You'll hear more about that in a future presentation. And any volunteers that you have on your communication plan. You want contact information for federal, state, and local emergency preparedness staff, and making sure that you're notifying DPH on a few different levels, quite honestly, to make sure that we're aware of the emergency. And there's continued standards underneath the communication plan that you would want to look at to make sure that your plan is incorporating all of these requirements. Training and testing. The long-term care facility must develop and maintain an emergency preparedness training and testing program that's based on the emergency plan, risk assessment policies and procedures, and the communication plan. The training and testing must be reviewed and updated at least annually. You must train, initial training the emergency preparedness policies and procedures to all new and existing staff, any individuals providing services, provide emergency preparedness training at least annually, maintain documentation of the training, and demonstrate staff knowledge. And for testing, the facility must conduct exercises to test the emergency plan at least twice per year, including unannounced staff drills using the emergency procedures. Please document any of this testing, because that's something that our surveyors do identify, that people say, oh, we did one in March, but there's no evidence that it was done. So we have to be able to understand and have proof that you did actually perform the testing. So we have some most frequently cited deficiencies. I added this one a little late to the game because it's not an emergency preparedness tag. It's actually a K tag under the life safety code, but it's the electrical systems, essential electric system maintenance and testing. It is the generator. We, in fiscal year 2025, cited the generator 168 times because facilities are not maintaining and doing the appropriate testing of their generators. So it's super important to make sure that K918 is a focus for you all, because with most of our emergencies, especially the natural emergencies, the generator needs to be working and functioning. And if we're not testing it and make sure that it's maintained, it will not be working and functioning. So we definitely take a look at that one. This is just an example. A facility failed to do monthly load testing to achieve the minimum of 30% of the EPS nameplate KW rating, and they failed to provide an annual load bank test as required. And also documentation failed to include monthly testing and recording of electrolyte specific gravity or battery conductance testing for the facility. So overall, we're looking to make sure that you're following not only the emergency preparedness plan, but your generator is in working order. The emergency preparedness plans that citations that we see most frequently cited, number one is actually the condition of E0004 for developing the EP plan review and update annually. So we're finding that annual updates are what we're identified aren't being done. That's why I've stressed it through almost every slide. Long-term care facilities need to annually review and document that they've reviewed it and updated their plan. An example of this is that a review of the emergency preparedness plan conducted on XX date found no documentation of an annual review update. And as a result, failing to provide annual, the facility failed to ensure compliance with the requirements, and it could affect all residents. So that's where you'll get a wider scope citation. It will be an F versus a D. So I think almost all emergency preparedness tags are considered Fs because it would affect the whole facility. EP training and testing. This is another one where the administrator, where the facility failed to develop, establish, and review and maintain your policies and procedures. So you want to make sure that those are updated and reviewed annually as well. Development of the communication plan, I had mentioned this earlier. We find a lot of times where they're not updated to reflect the newer administrator, the new director of nursing, maybe the new maintenance director. And if you've had a change in ownership, sometimes it's got the old owner's name. You have to update all your policies and procedures to your current ownership group, whomever that is, because it needs to be facility specific. It can't be, even though the facility used to be named something else, it needs to be very facility specific. So if you're an ownership group that owns multiple facilities, you have to make sure that they are individualized per facility. Plans based on all hazard risk assessment. So once again, it's the risk assessment, the all hazard assessment. 17 times, I forgot to mention the last one, I believe 21 times for development of plan of communication and 26 times for the training and testing. Sorry about that. So just making sure that your all hazard risk assessment is updated and thorough, and it's facility specific again. And policies for evacuation and primary or alternate communication. Once again, that's another one that when it comes to the communication plan, you have to make sure that the policies regarding evacuation of the facility in the event of emergency. A lot of facilities have a plan. They think they have a plan, and then all of a sudden they need to evacuate and they're not prepared. So making sure that you're not only creating these policies, but you're able to have them be put to work is super important for the safety and well-being of not only the residents, but the staff members. If there's a fire, if there's a flood, if you've had a boiler issue, you want to make sure that if your residents need to leave, they're going to be leaving safely. You know who they are, you know what medications they're taking, you know who their emergency contact is. So to follow up and to end, the emergency preparedness and long-term care must be unique to your facility, include the four core elements, which is plan, policies and procedures, communication, and training and testing. Emergency preparedness program is a requirement of CMS conditions of participation to protect the residents and staff during disasters and emergency situations. That's all I have for today. I know I speak quickly, but I put a lot of information on the slides for you all to be able to sort of digest them and read them and help you build a more robust emergency preparedness plan that meets the four core elements.
Great. So, Katie, thank you so much. And I just want to remind everyone that these slides will be shared afterwards. And there's just, a lot of really meaty content in there. So next up is Jim Garrow. Jim is Senior Fire and Emergency Management Consultant at Jensen Hughes. Jim's an expert in emergency readiness and emergency management. He's going to be sharing a real world example to illustrate effective practices. And he also has a planning tool that we will circulate along with the slides after the webinar. So Jim, over to you.
All right. Good afternoon. Everybody can see my screen okay? Yes, beautiful. All right, it was a lot of people on here today. It was nice. I saw a lot of familiar names popping up, so it's nice to see everybody. I'm going to take you through a couple things here. One was sheltering in place, and some part of that is having an internal surge plan of, where would you move people, and we'll go through that here. As I take you through this, really, I'll start with a case study, it goes back a couple years now, but it is so important of what transpired with these guys and how this really worked too. We're evacuating and then, we can't go anywhere. And now it became sheltering in place and how do we keep people safe. So I'll talk about that, your internal search plan, and then a search tool at the end that we're going to give you guys to help you identify this space. So this was in Leominster. This was again a couple years ago. It was about 6 o'clock. Our resource officer got two phone calls, one from a nursing home, one from an assisted living. The nursing home called to say, we want to put you on notice. We may be evacuating, but our sump pumps can't keep up. And we've got 3 feet of water in the basement. And the electrical panels are like, we got a foot to go. Waiting on the fire department to get some pumps warm. They did show up just in the nick of time, got some pumps in there, pumped out the basement. They were okay. We also got a call from an assisted living facility. They had water coming in through the back door, down an embankment, into the back door of the facility. The PTAC units, the heating and air conditioning units that are in the walls, they had water getting pushed into it as well. So they were 81 apartments, independent, assisted. And the scary part here is memory care. Memory care in our world is very difficult to, as you guys know, you don't have many open beds. So when we need to evacuate a facility, either assisted living or nursing home that has memory care, it can be a little bit of a challenge. This building was not in a floodplain. They never had water that entered the building before. 5 o'clock facility staff members start to head home. By 6, they got water coming in, like we said, the rear door. And if they started calling staff back, by 6:15, 6 inches of water in the rear hallway, and the water's pushing toward the front of the building on them. So the call to us is, we got to get out of here, which totally understandable. They call the fire department at 6:15 to say, we need some pumps. They would think about this. You call 911 asking for assistance, and you're told, okay, you're on the list. What does that really mean? Just what it said. They were inundated. They were on a list, and they did get help, but it took a little bit of time. That is why you always hear us preach in our mass map education conferences. And listen, you need to be able to be self-sufficient, be able to take care of yourself, because in a major incident like this, you may or may not get, when you call 911, they may or may not be running to you. And this is a classic example where they didn't. So at 6:30, they attempted to get through the rear door, unclog the storm drain. They couldn't even do it. They had to open up windows, go out that way, and get in there and try to start removing the debris. The residents were moved early on to the front of the building to get them out of the water. Now, and so they started looking at apartments that were under renovation. Where are they in that state that we could start using that and using those apartments? They also looked who's going to need to be evacuated. Could we leave our second floor residents there, move just the first floor? So that was a process that started. Shortly after 7 o'clock, they literally really became an island. They were not going anywhere. Nobody was getting into them. The fire department was afraid to even drive an engine over to them because of a bridge that they didn't know if it was compromised or not. So they came over in the smaller trucks, but they certainly wouldn't drive an engine in there. But they realized that shortly after 7 that this is not, they just are not going to be able to evacuate. So with the resource officer that was on, myself, the gentleman from the administrator of the facility, we started having discussions about, all right, we're flipping the coin. You're not evacuating, you're staying. What do we need to do? How can we help you set your building up to start supporting and being able to having, keeping residents safe? And they determined they were coming up and going, bringing everybody on upstairs. So they did that. And it really talked about surge space. How to house residents is really, especially their challenge was the dementia residents. So they converted memory care dining room and other rooms to surge areas. It's all about pre-planning with this. We did this in last year's exercise. We gave people the option of doing a full building evacuation, or do you go internally and surge? So the scenario they had last year, and it will be something similar this year because people learned a tremendous amount from it, and we're going to want them to say, all right, what we learned, we updated our plans, and let's test it again this year. But we basically said you lost one side of your building because you had a sprinkler pipe burst, and now you're pushing everybody to the other side of the building. And where can you take space and put them in there safely? And that's one of the things we'll talk about next is how you can do that. So some examples of shelter in place examples, your blizzard ice storms, they are an area where you just can't go anywhere. I can remember years ago, we had a building that was down in the Plymouth area. We had a huge blizzard. Route 3 is shut down. There's trees, there's snow, and it's like you're not going anywhere. You're going to be going to other nursing homes in that area, and that is really the discussions that we had. Who can surge and how can we get these residents in there? Minimal fire or smoke in one compartment. So if you have that, that's what the example I just gave, you have a smoke condition or you have a sprinkler pipe burst and you move to another compartment that's safe and keep everybody there. We just taught you just heard about the from Catherine about the flooding of I'm very happy we had that. We used to have a tremendous amount of people activate mass map for frozen sprinkler pipes and massive flooding and evacuate their buildings. Knock on wood, we haven't had one yet. And I'm happy to say we're finally over 30 degrees, so we might have escaped it. But this was caused this tremendous amount of damage. But if residents can be moved to another part of the building that's not impacted and the fire suppression system can be repaired and you're all set with that, that is another area where it's, sheltering in place. I got to tell you, when you look back at a lot of these evacuations, especially from the Katrinas, the Superstorm Sandy, there's a thing called transfer trauma. And residents, it's gotten better over the years, but Katrina had a very high rate of resident deaths 90 days post evacuation. We saw the same thing again, not as many in Superstorm Sandy, but there's always that transfer trauma. So anytime we can have residents stay safely in the building and shelter in place, the better off they're going to be. And it just works out. It's just better for everybody, your staff and everybody there. So we have this algorithm that's it is part of the EOP that we have that when we design plans, and this is on the Mass Map website as well. But this algorithm kind of walks you through, am I going or am I staying, right? I mean, because that if you stay and something bad happens, you're going to need to explain yourself. And this is just kind of a guidance of, consider future issues that will make evacuations difficult. So what are the road conditions? Are they flooded? Do I have downed trees? contaminated air. You got to stay put. So if yes, you have that, you shelter in place, or if you're going to evacuate, what are some of the critical factors if you evacuate is, where you're going. Yes, Mass Map can help you with that, but what supplies, equipment that you need to go with you? How are you going to do, how are you doing, you coordinating transportation? If you're sheltering on the left side, shelter in place, well, that's, you're protecting structures, provide the best option to shelter residents and staff. Conservation plans, start thinking about that. If, everybody just did a questionnaire for, everybody feels pretty comfortable staying there, right? What was the hours? 96 hours, something like that. What's, are you going to need to conserve a little bit for some of that? So those are all things that, part of your discussion points and things you should be thinking there. Again, as far as just a decision-making guide here, as far as, if your decisions needed to shelter in place, these are just some of the assessments that you should be doing of your critical issues. So again, we'll start on the bottom left is, what are your structural utilities, supplies, security? What's your exterior environment? Could you go outside? Maybe you can't. I was just out in California working toward a mutual aid plan in LA County and listening to them talk about being miles away from these wildfires, but they couldn't go outside. They're shutting air conditionings down because the smoke was so bad. So again, perfect example of a shelter in place. They're not going anywhere. But on the flip side, boy, when they had to move quick because of these fires, they had to move quick. And some really good discussions came out of that one. But as far as, really just, other key things to be thinking about, weather, obviously, duration and scope. If this is like an ice storm, we've certainly been through some pretty horrific ice storms over the years. If you need to stay in place, you lose some of your building and you need to keep people safe, you should be having an internal surge plan, right? Which is what that is an option for increasing your capacity. It really helps for adding additional beds to potentially existing sleeping rooms. So going from private to semi-private. A lot of folks have rooms that were semi-private in the day and now they're privates. Well, now can we go through and make them semi-private? When you're looking at these spaces, consider looking at space that is, does it have emergency power? Do you have your red plugs in the room? Do you have lighting in the room? When you look and get outside of your resident rooms, some other areas, can you transform non-sleeping areas such as activity rooms, lounges, dining rooms, auditoriums? There's a lot of different space there. And then you need to kind of figure out where would we prioritize that and what areas would we be doing? And I'll show you that in just a second. But when you're doing surge space, make sure that you're not reducing any life safety features. I am not a big fan of putting, like we don't want to have you put people in hallways because if there's a fire and you have a smoke condition, you want everybody behind a closed door. So it's utilizing these rooms but making sure that you have the life safety features there, you have doors that can shut. If you're looking at a big auditorium, you can do this. I mean, we've got some pretty horrific photos from years past where people were setting up and using these like school auditoriums and there's a cot every foot away from each other. Pretty much we look at, you want to maintain a 3 feet between each bed or cot. There's a big difference, by the way, of having a medical grade cot versus a regular cot. The medical grades can raise, a regular cot cannot, and residents do not do well in those. 4-foot egress path to the exit, and then, this is just kind of an idea, a general gist to just kind of give you to set up a room. Again, if for you folks that are Mass Map members, we do have this under Influx Surge. This is tools that you can get. This is one of the tools we're going to give you. This is an Excel sheet. It's actually, you can print them out 11 by 17, or even it's smaller. 11 by 17, they work really nice. This is a tool and it will aggregate for you, but let's just walk through this for 1 second. If you look through what we're gauging here is I want you to go through and use this and figure out where is a good place where you can surge to. So if we go through and say, I'm going to surge A wing and take all the rooms that are private and go to semi-private. Well, that's easy to do, but that would be a high priority area, but what are you going to need to do that? So we could list and say, all right, it will be A wing, it will be its ability to set up is pretty quick because if it's like a rehab area, that could take a while because you got to get all the equipment out. Your search priority, that could be a high area. I can put 10 more residents there. What kind of staffing do I need if I'm going to do that? And then what do I need for beds? What do you have on hand? What are you going to need to bring in there? Then we give you some, as far as equipment and tap bells, is it secured or locked? And then on the last column is instructions to set that up. What are you going to need to do? Um, does it have emergency power? Is the bathroom in the room or just outside the hall? Um, I have the piped oxygen suction and air there. So you can feel a lot of people do remove that, but we do have some facilities that do have that. And then any notes. So what's nice with this is all of this will aggregate for you. So you'll know and I would recommend that when you go do this, you do it as like your safety team. Everybody's going to look at this different. Your facilities guys looking in there and going, all right, what do I got for red plugs? Your nursing is like, how am I going to set these rooms up if you're outside of a resident room, right? But when you start looking at activity rooms and all of those things, you just kind of want to get a lay of the land, and write the note in there, how you would set that up. So this is a tool that is very helpful to help you gauge how many people can I put into another wing? If I lose my B wing, how many can I put here? You may say I can use this surge plan, I can double up on this area, and now I've got it doubled up, but I still have 20 more residents that need to be evacuated, right? So this is where you can help this. When you surge, in our surge plan, we have two things you need to do. One, notify DPH. Hey, listen, we're doing this. Notify your local authority having jurisdiction. Most of you guys have your EMS is your fire department. They got a pretty good idea knowing you got 100 residents. If all of a sudden they walk into an area and those 100 residents are all over on one side of the building, they're going to want to know why. So we always say that notify in the plans is doing those two notifications. That's my spiel. Hopefully I answered the questions. You kind of heard what you want. For you guys that are going to be going to the annual education we are going to have this, but I can talk a lot more about this and didn't have the time, but this is going to be one of our topics where we get a little more in depth. We'll give you these tools as well. So, all righty.
Great. Thank you so much, Jim. That was fantastic. Uh, Getting more questions about the slides. Will they be available? Yes, they will afterwards. And so don't worry about that. So now we're gonna switch over. We're going to hear from three skilled nursing facility leaders who are going to talk about their recent experiences with evacuation and sheltering in place in response to emergencies that they've encountered. Now, these are going to be kind of rapid fire presentations. I don't believe any of them are using slides. They're going to tell you just quickly kind of what the event was, what happened, what they did in response, what worked well, and what they learned. There's always something to be learned from these things. And then after that, we're going to move into a question and answer session where you'll either be able to raise your hand and speak up, or you can put your questions in the chat. And we would encourage you to go ahead if that's what you would prefer to do. If you're going to be chatting questions, you can be writing them in. So, as I said, rapid fire, they're going to keep their remarks relatively brief, but they will, all of the presenters will be available to answer your questions afterwards. So first up is Rodolfo Parra, who is CEO of Holy Trinity Nursing and Rehabilitation Center in Worcester. And he is going to describe Holy Trinity's recent response to a loss of power emergency.
Hello, everyone. I hope everyone can hear me well. So I'm Rodolfo Parra, the CEO for Holy Trinity. We are 113 bed. So on November 26th, the day before Thanksgiving, we had some normal schedule work for a generator, and that led to an electrical surge. So what happened at that time is when they came to do the fix our generator, It fed our generator, so pretty much anything that was connected to the generator got impacted. So that's like our heating system, our boiler, our HVAC, resident bed. A significant impact. And this happened right before Thanksgiving. And the first thing that we did when that happened is that we started like kind of assessing, do we need to evacuate? Because if you recall back in November, they were projecting a cold, like the temperatures were going to go low. So we knew that we didn't have any heat or hot water. So we were starting to evaluate, do we need to keep the room, do we have to evacuate because the temperature is going to go down, which will not be habitable for the resident, or can we shelter in place? So we kind of do a couple of things at the same time. Obviously, we notify DPH, we notify the state, mass map, we notify our partner nursing home in case we had to evacuate. So we kind of did it parallel. So we automatically started like planning for an evacuation. So we had 105 residents at that time. So we were identifying, we were happy to identify all bed for those residents. We identified who need wheelchair, their medical need, their medication. So I had like a team who was kind of getting the evacuation so that while I was still evaluating what to do with that building. In that process, one thing that me and my maintenance director identified is that while the heat for the resident room were not working, there was heat in the common area. So all the hallway, all that common space, dining room were heat. And we identified that we actually were able, if we leave the resident door open, we were able to radiate enough heat to the resident room that they didn't need to be evacuated. And we did, we checked, and we were here at about like 4 in the morning. I guess Thursday morning, because Wednesday night to Thursday, to make sure the temperature was still impact. But we didn't have to evacuate because we assessed. We said no, we can actually stay in place. We have enough heat to radiate. And in the hot water, we ended up ordering like more like the incontinent product more, so we can use that. In our hot water, we were able to boil our water, which is good too. So the good thing is that we didn't have to evacuate. But one of the things that I think my watch, right? But I think one of the things that make it, because we are a standalone building, we do a lot of drill because I don't have any corporate people to call. Like I don't have nobody to call by myself. So we do a lot of drill, and we make sure that when we do drill, the staff can actually perform. That they can actually do. So we do like not just our fire drill, but we do like emergency preparedness. We do lights of public. We want to see how our frontline staff can respond to that. And that's why I think that helped us, and it was evident that the staff knew what to do. They put a plan in place. I mean, I was here already, but if I wasn't here, they still would execute the plan as it is. I think in terms of like learning lesson, one thing that we probably did learn is that I think because it was Thanksgiving and the staff didn't really understand in the beginning, like the impact of the surge. They thought, okay, we lost some power, the power came back. They didn't realize that the hot water was not working, that the heat, that you couldn't get somebody to come and fix it because of the holiday time, that resident bed were impacted. So they let some stuff go earlier. And one thing that we went back to them and said, if this was to happen, we should have let, I mean, luckily the staff came back, but I wouldn't have let any stuff go until we can ensure that everything that we have a plan that staff and residents were able to remain safe, and that if we had to evacuate, we had enough body. And that's one thing, which is really understanding the gravity of the situation, that it didn't appear that nothing was impacted until you start really assessing the whole building and all the unit of the building that were impacted.
Thank you so much, Rodolfo. That was that that these stories are really compelling, I know, and that's so we have two more to share. So I'm going to move on to Todd Funk. Todd is administrator at Webster Park Rehabilitation Marquee in Rockland. He's going to describe their recent response to a fire that caused smoke and water damage. Todd, over to you.
I want to make sure everybody can hear me okay.
Yep.
All right. So his was 2 days before Thanksgiving. Mine's 2 days after Thanksgiving. November was not a good month. So at 4 p.m. Saturday afternoon, going into evening, we had a fire alarm activated on the 3rd floor. And it was because of an electrical fire. There's an exhaust fan in the staff bathroom right next to the nurse's station. Sprinkler functioned in the bathroom, which helped contain the fire until Rockland Fire Department arrived. So they came at 40444. The ladder truck came through, brought a hose to the third floor, and used the hose above ceiling to further extinguish. A total of 16 HNCs were called in as well. So therefore, the water damage was the main reason for evacuation. Fire was small, water was great. Water flowed from the third floor down to the first floor, hitting all floors. So staff, I'm breaking this down a couple different pieces, but the staff began evacuating residents from the rooms on the third floor prior to the fire department, lining them up at the stairwell exits, including some bedbound, began carrying residents down the stairs in wheelchairs to other floors. Most were evacuated prior to the fire department arrival, but fire department completed evacuation of the third floor for remaining bedbound. Staff from other floors came up to assist. Evacuation of second floor was next, removing all residents down to the main dining room on first. First floor residents sheltered in place, those rooms not affected by the water until time to evacuate, moving them to the main dining room. So DPH obviously was notified earlier on in this, but I just wanted to give you the whole recount of the fire. So it was MassMap. I was speaking to Jim Garrow. So I met with the fire department and they mandated the full evacuation, but fortunately they were giving us a little bit of time to put this together. At first they wanted them out the door. It's kind of what they do. But at the same time, I said, let's plan this a little bit. Marquee has a network of nursing homes in the area. So our corporate staff came in and assisted placing residents at a lot of our sister homes. So we evacuated 99 residents safely to 11 different SNFs, 9 Marquee and 2 others, and not one of our residents or staff to send an injury of any kind, smoke, water, everybody was safe. So the evacuation process, real quick, we had separate workstations, area for assigning placement of residents, staging area, clustering residents for transfer to receiving facilities. Then upon exit, place plastic bags we had for resident belongings, which had everything, could have 2P, but meds, face sheet, transfer, discharge record. So admission staff at that point, before the resident was actually discharged out the door, is notifying the healthcare proxy and emergency contact for placement once placement was determined. All right, so one of the things we learned, this is water damage, and we did remain on street power. However, the water damaged our server for our copiers. So I didn't have a way to print out the transfer discharge, face sheet, and the med list. So we sent a nurse over to a local SNF that actually had point-click care, which we knew. It's a longer conversation, but went over there, printed off our face sheets, transfer discharge records, and med list, came back and finished our evacuation process with our residents. And then, of course, power was shut off right after we discharged our last resident. The only thing, not the only thing, there's a lot to this, but I'm supposed to be brief, is you can't over prepare because you don't know when it's going to happen. You have no idea what your staff is going to do at the time of emergency. You know, are they going to run downstairs, run out the front door, get in their cars and go home? Everybody acted as they should. It doesn't always happen that way. I don't want to take anything away from my staff. They did a fantastic job. But you just realize, wow, these drills, they actually put it into place and actually functioned properly as far as an evacuation process. That's my speech. That's my story.
Thank you so much, Todd. Now we're going to move on to our final rapid fire presentation by Tara Coughlin. Tara is Regional Director of Operations at Integritas Healthcare in Pittsfield. And she's going to talk about her facility's response to a loss of air conditioning in a dementia unit, which I can probably guess did not happen around Thanksgiving, given given what the nature of the event was. So Tara, please go ahead.
Thank you. Good afternoon, everybody. Our situation happened on a weekend in June. Temperatures were rising. It was a beautiful day on Cape Cod, our Cape Cod facility. Unfortunately, on Saturday, on a weekend, lost a 2-ton rooftop unit that managed the entire 41-bed secure unit, which housed primarily our patients that wander, behavioral patients, and patients with dementia diagnosis. The event started on Saturday with the team of maintenance and electricians trying to fix the air conditioning unit. Parts were ordered. They were expected to arrive on Sunday. We were able to manage the residents in their rooms with the lights down, hydration carts, regular snacks, visits from more nurses, vital assessments and monitoring for dehydration. Temperatures on the unit were in the mid 70s. It wasn't too warm yet. On Sunday, the temperatures began to rise outside and inside. The sun was beating on the second floor. We brought in portable fans, portable ACs. However, temperatures were unable to get below those mid 70s, rising into the 80s inside, and the outside temperatures were continuing to rise. And we were expecting a heat wave that was supposed to come actually on Monday and then extend for several days. So on Sunday, we started calling in extra staff, started to prepare and think about what would be the plan moving forward. The company continued to work on the rooftop unit. The new parts came in. Those parts, unfortunately, were not sufficient to get the unit up and running completely, and they would need to put a hold on the project. And on Monday, they were going to get back to us after they spoke to our engineers. So now on Sunday around 4 o'clock, again, the sun is setting and it's beating down on the second floor. We had to activate our internal surge plan and decided we had called extra staff in at the same time as they were working outside. We started to move people down to the ground floor, which is where our activities room and dining room was located. The dining room was able to house quite a few folks. We have drop ceilings there. We were able to put privacy curtains up. We were able to just take those tables, move them right outside into the courtyard. Patients were moved with their beds. We left their belongings obviously in their room. Staff needed to be assigned to doorways. Those rooms had multiple doorways, either going to outside, going into the kitchen, going into the hallway, but these were wandering residents. So we needed to have enough hands on deck to cover for that security that we had on our unit that we would not have on the first floor. We started our communication with our home office out in Pittsfield and communication with DPH staff, residents, families. And we were able to keep everyone status quo through the night, and everyone remained safe and hydrated and positive in those shelter-in-place areas. Monday morning, woke up, it was a little bit cooler. Again, they all had air conditioning now. Owners of the repair company met with our maintenance staff, and ultimately it was determined that we could not repair this 2-ton air conditioner. It would needed to be completely replaced, and we would not be able to receive one. It would take approximately a week, is what we were told at that time. Of course, things happen. The reason why I'm presenting to you today is because the administrator was passing papers on her new home at the time. I was actually returning from Europe, came in late Sunday night. My boss was communicating with the facility, and that early that next morning, I headed on my way down to the Cape. We had a team meeting and decided, again, similar to what Jim had said, walking through our options and our scenarios. What were we going to do if we could not fix this rooftop unit? How long could people stay into the dining room? It was determined, with our clinical team and others, that we could not keep people in that dining room for a long period of time, and that we would need to likely evacuate if this rooftop unit was not able to be repaired within a day or two. And it was not. We ultimately had 41 residents. We were able to move 8 of them to other beds in our own facility off of that unit, and we had 33 residents that would need to be placed elsewhere. We did something a little bit different. Again, these are patients that were high-risk patients for behaviors and dementia and wandering. We took those patients, we put them on one-to-ones, we relocated them to our short-term rehab unit, keeping the most difficult patients in-house, and then we were able to send 14 residents to other of the Integritas facilities in the local area, and the remainder went out to 6 different Fortunately, thank you to the Royal team, they took most of our residents that needed to be sent outside of our Integritas family. We decided that we would have, to make this happen, administrators from our other local sites arrive on scene to help working with which residents they were going to have come to their facility so that we would have more hands on deck. We used the holding area resident departure form along with the resident medical record and equipment tracking sheets that I'm sure can be found on the Protect Advisor site. And that's how we were able to track people that were in the holding area, and we used them to track our medical records. We used them to track where the patient was going, what equipment they went with, what meds they went with. We had previously, the day before, started copying our medical records. We kept them in a box in the command center should we would need to do an evacuation. And we were also working at the same time with multiple things happening. We were keeping up with giving reports to the command center every hour. Throughout the day, we continued to provide the hydration. We had provided the communication. We continued to have checks of the temperatures throughout the building consistently. And again, throughout the time, there was multiple moving parts. I was able, because again, I am coming in not having access to the facility's information, and maintenance is at the scene of the emergency. So, and on the roof the entire time this is happening. So as you can imagine, it's more difficult and one of my lessons learned is the number of people that need to have access to Protect Advisor and understand the system and the process in every building. Not just your maintenance director and not just your administrator. So that would be my shout out to you guys, is to make sure that that's something that you're looking at. But anyways, I was able to find in my emails the Han information and the duty officer, which I was able to reach out to and get connected. I also connected with Jim Garrow, and we were able to start to put together the information that I needed from Protect Advisor. I had access to all of the beds available in the local area, as well as those that were able to take dementia patients, as well as transportation information. We were able to send out a Han alert for transportation. We started to get calls from facilities that were able to support us. We were able to bring in our ambulance company. We started bagging our meds. We had the Bourne Fire Department on scene. Our contracted ambulance company was able to come on scene with a team of people to help with transfers. We used the contracted ambulance companies from our other two skilled nursing facilities that were accepting patients. They were able to come and pick folks up from our facility and relocate them to their areas in New Bedford and South Yarmouth. We also have communicated with families throughout this. We used a voice friend system, which is able to send information through text and emails to family members and staff at the same time. We also were calling family members when they left the facility, when they arrived at their other facility. We were able to work with our local ombudsman, notify our MDs, NPs. And again, we had people even working from home that was able to help support with documentation and work electronically that weren't able to come into the building and help us with access to the medical record from home. Ultimately, transportation was our biggest need. We had found many of the facilities that we were able to send people to, but transportation is a challenge. We did end up with 2 local assisted living facilities helping us and providing vans for us to transport people back and forth. We also had the 2, actually we ended up with 3 ambulance companies supporting us as well. And by 5 p.m., we had successfully evacuated 33 residents out of Bourne Manor and into other facilities. We were in constant contact with DPH, the emergency officer that was on that day as well. Unfortunately, moving forward, there were days that went by that we were not able to get this rooftop unit replaced for quite some time. Those of you who may not know, those patients remain yours for 30 days, and we just made it in the 30-day window to get our patients back. And by 7/18, all of the building had been restored to normal practices. We had a brand new air conditioning unit, and everybody had returned to the facility with the exception of 2 residents who, one had passed away peacefully with family. That was a hospice resident, and then another one had decided with patient choice to remain at the facility they had been evacuated to. Some of the lessons learned that I want to share with you, again, please think about having as many people as you can be involved in Mass Map and Protect Advisor and understanding the system, as you never know when your maintenance director will be at the scene of an emergency, and administrator could be out of town, not available. Director of nurses was completely involved in working with staff. We had to send staff to other facilities to help assist with residents. We had to put residents on one-to-one. So the director of nurses was completely consumed with patient, working with the patients, was not able to drive the emergency. Therefore, you want to make sure as many people have the information as possible. The other things we suggested was large hydration coolers for both the staff and residents on hand to be able to get that quickly in place, as well as handbells available. And those headlamps that are lights for the nurses to be able to use those when we want to keep the lights low and they are able to go in. We do not have night lights in our dining rooms and activities rooms, so those were needed at nighttime to assist in the holding area. And I think that would give you kind of a summary of where we're at.
Thanks so much, Tara. So we have about 15 minutes for questions that you can direct to individual presenters. You can direct generally. I know you've put a number of questions already in the chat. You also will have the ability to use the raise hand function, and we can unmute you and you can ask your questions out loud. In the meantime, we just, as you can see, put up a poll. It's an open-ended question. If you have topics that you'd like to see us cover in future webinars, just please type them into that box. We'll also give you an opportunity with the evaluation afterwards if you have questions later on that you think of. So we'll keep this poll open for a couple of minutes while you do that. But in the meantime, why don't we, does anyone have their hand raised? I'm not sure if I can see. Charlie is going to actually, he will read out some of the questions from the chat. So why don't we start with that?
Yeah, if Katie is still here, this question was asked during her presentation. Does the testing of the emergency plan have a requirement for off shift, so nights, weekends, holidays? So Katie, if you can help address that. Jim,
Sure.
Also, if you have any insights, that'd be helpful. Thank you.
There's no actual requirement for off hours actual testing, but they do recommend, or it is written in the fine print, and it's now in red because there's been updates, that you're identifying all staff. So if you're doing these emergency testing, making sure that staff that might be working that Saturday, 3 to 11 shift is participating in the testing. So we're not looking to disrupt the residents in the middle of the night or anything like that, but we are definitely making sure that all the staff, like I know that when we spoke of, Webster Park, that was a Saturday afternoon. Those staff could potentially just be weekend staff members. They were all very well versed in how to safely evacuate the residents once the smoke alarms went off. So making sure the staff working all shifts are trained and testing with them, but doesn't have to be in the off-hour shift.
I'll just add one other thing here, is I can tell you that I've been doing this a long time and been a paramedic for over 30 years. Nothing, this never happens Monday through Friday, 9 to 5.
Right.
It's right, never. So we actually took, last year was the first year, and we're going to continue it this year. For the Mass Map exercises, we're doing afternoons. So it starts at 2, goes into the evening shift, and we had a lot of great feedback to where evening shift came in and just jumped into the exercise so they could participate in it. So we're going to continue that this year.
Great, thank you. Another question, I think for Katie and Jim, others might want to jump in. This question was referring to the Brockton hospital situation a few years ago. But the statement is, having a plan is excellent, but when the state becomes involved, the plans can end up being changed. And so the question is, how do organizations coordinate with the state before there is an emergency situation so that they can implement their plan?
Well, for us, specifically, I wasn't part of the Brockton one, so I can't speak to that in particular, but our life safety code surveyors are in there every year and they're reviewing the plan to make sure it's appropriate. So just making sure that you're following through with your plan of correction if you do have deficiencies, and if not, making sure that if you had no deficiencies, you're continuing to keep the systemic plan in place so that way it works when there is an emergency.
Thank you. Great. Jim, anything to add on that, or?
No, well, the only thing I would say is just, it all goes to training, testing, right? So if people are trained, well-versed, know their roles, I think when first responders get there, DPH gets there, if they see that things are managed under control and going well, nobody really should intervene.
Mm-hmm.
Bottom line is resident safety, and if that's being done and taken care of, then it should be good.
Great, thank you. Barbara, Michelle, have there been any hands raised? Or I'll keep reading the other questions I have. Okay. There are just some very specific questions that came up during rapid fire discussion. So when Tara was talking about the many steps that were taken during that situation, there was a very specific question about transporting narcotics, whether there are best practices. And there was a comment from another participant or attendee that in their experience, a new prescription order the receiving facility is preferred when possible. But for any of our speakers, panelists, any comments on how to plan ahead in terms of narcotics and ensuring that the meds are available for patients and residents on the receiving end?
I can speak to that, how we handled it. We had that very question come up during our disaster. We actually had folks that were helping us to transfer that were maintenance folks from other facilities that weren't comfortable carrying the narcotics with them to the other buildings. We actually had a nurse just deliver them to another site. We had them sign off and we had them bring them to the facilities that they needed to go to. Once the patient was transferred to the other facility and all of the medications that we had on hand, we had them start ordering from the accepting facilities pharmacy because it would be too complicated to be able to have them come through our pharmacy and then be sent to the patients. So we had them, and then we just dealt with the financial implications later, which could be a whole nother conversation, but definitely that's how we handled it.
Great. So there is one hand raised, Jasmani Ortega, if you would like to unmute and you can speak up. Great. Go ahead. Jasmani, we can't hear you. You are unmuted, but well, why don't we, there is another question in the chat, but why don't you, maybe we can try to work on your microphone in the meantime.
Sure. Or just Manny, if you'd like to write it into the chat, we can certainly read it out for you. Another question, actually, this came up, Tara, when you were speaking, whether it's okay to use a mattress on the floor during an emergent situation.
Yeah, I think we would have used them if we needed to. We were able to accommodate the entire bed. They fit through our doorways. They move down the hall quite easily, actually right through the elevators down the second floor. But had we needed to, we would have done that.
Thank you. And I just have one more question that was entered in the chat earlier when Todd was presenting about his organization's experience. This question specifically, Todd, did your organization use the triplicate evacuation forms from MassMap?
Yeah. Excuse me. Yes, we did. As a lot of us do, we all have their big boxes full of all the gear and the documents. So that is part of the package.
Thank you.
I'll just add to that. We've had multiple evacuations in multiple states, right? And people that do not use that tracking form, the medical record equipment tracking and all, it's a nightmare because they're usually working with a census sheet and they're trying to figure out where people are, what they're doing. That once we get on the line with them and they start using that form, we hear that like, oh my God, it was just so much easier. And it's so much easier to reconcile at the end. Where is everybody, right? So it's definitely That's been tested time and time again and proved very beneficial.
Great, thank you. Uh, question that just jumped in. Sounds like we're already sharing some good ideas here. Just ordered headlamps. Anything else that was super helpful to have on hand? Tara, I think you mentioned that was really helpful to have for your staff.
Yeah, your hand bells, just regular bells to have at the bedside table of the residents. You have enough for your whole building. You know, you never know how many people you're going to need to move to a holding area, so having those available. And again, we had on hand from cookouts those large, I think you get them at Home Depot, but containers for fluids that can be kept in areas, because you're not only hydrating your residents, but your staff as well. We've got to keep them moving as well. So that was something that was very helpful.
Thank you. Jim, Todd, can you just repeat the name of the tracking form again, please, so people know what you're referring to specifically?
Sure. It's the mass map tracking form. We have two. One is for a resident medical record that if they are unable to use electronic medical records or anything, this is a triplicate form. The other is the tracking form. And both of those you can get through Mass Senior. You can actually go to our website and you'll see an area there where they can order, or they can just reach out to Mass Senior Care and they can connect them.
Great, thank you. Lots of good resources out there. Okay, Barbara, that's everything that we have in the chat. And you're still muted, Barbara.
Last call for any questions if you want to raise your hand, but otherwise just want to extend our sincere thanks to all of the presenters. This is great. I knew I would learn a lot. I did. And we hung on to most of, I think we were up to almost 350 attendees. So this was, hopefully a worthwhile use of everyone's time. I see some messages in the chat saying that it was a great way to spend their lunch hour. So I know you've been responding to the poll about topics you'd like to see covered in the future. We'll give you an opportunity when we send out the evaluation, the materials to add to that list if you'd like. And thank you again. And we hope to see you next time.